We are starting the final panel of the day. The final panel of the day. The chair of this final panel is me, so I don't have to walk a lot to the stage. Our panel is called The Pandemic and Challenges of Public Health. I invite everybody who's still at the coffee break to come back. So let's begin. We are used to talking about COVID and the pandemic in the past tense. However, there are many questions still unanswered that are very much relevant. Relevant not just for public health professionals, but to the wider public and the policy making today, and even more so in the future. Questions about COVID's impact, not just on health, but on long-term consequences, on longevity, on a number of productive years of the workforce, on economic productivity itself. Questions about preventive measures, about treatments, the much avoided issue of long COVID, and also questions about systemic resilience, be it from supply chain perspective or the issue of trust in the society. Our experts today will help us navigate this topic. And our experts today are Nisreen Alwan, who joins us online, Professor of Public Health at the University of Southampton. Hi, Nisreen.
Hi, nice, very honored to be here. Thank you.
David Stetson, a researcher at Vanatech, who is here with us. And now Maria Libura, Head of Department of Medical Education and Simulation from University of Warmia-Mazury in Olsztyn. Hi, Maria.
Hello. Thank you for inviting me.
So Maria was supposed to be here with us today, actually on the stage, but you know she tested positive for COVID. So we are taking COVID seriously. We don't think it's no longer an issue, and for the good health of everyone, we try to test as much as possible. So thank you also, Maria, for caring about our health. Savante Wild from University of Oxford. Hi, Savante. And my name is Krzysztof Mroczkowski. I will be chairing this panel. I'm a board member of Europe-Patient. So our experts will help us navigate this topic, and let's face it, most of the people in the audience or watching us are not experts. So let's first make a broad strokes diagnosis of where we are regarding the pandemic and its consequences. I would like to start with asking each of you for a 2-3 minute answer to the question, what is the state of the pandemic and the post-pandemic aftermath? What are the big issues that societies and policymakers need to pay more attention to? And let's first turn to Nisreen Alwan, who is online with us. Nisreen, the floor is yours.
Thank you very much. This is a very, very big question. And I think I would answer it in saying there are two main things really here in terms of the pandemic aftermath. There's dealing with the massive ill health burden that the pandemic has generated. So navigating systems which are not necessarily the best in terms of dealing with ill health shaped by things like long COVID and the effects of getting the virus and all the other health effects, where we're hearing more and more research now on the various effects on the body of having COVID, and we probably hear more long-term effects. So how do we navigate and deal with that ill health burden beyond in the health system, but also beyond in terms of wider society, employers, our structures, our structures in terms of the systems we operate in. So COVID is still with us, as I'm really sorry to hear about Maria's illness, but this is a demonstration of the issue, that the issue is still with us. Obviously, things like vaccination have made it less dangerous. We know that vaccination is also linked to reduce risk of long COVID, but we still have a significant morbidity burden. So that's one thing, dealing with the ill health burden. How do we deal with it? How do we actually move forward in terms of serving the people who've been affected by the pandemic in this way? But also in terms of how we haven't learned enough about, reducing, how do we apply the learning about reducing the burden from, that we have got now from COVID, to try and avoid this happening in the future. So that includes obviously learning lessons for prevention of and preparedness of future pandemic, including things around multidisciplinary decision making, and really very important lessons for us in science and public health around science communication and how we can do this better. But also on a normal everyday level, how are we applying those lessons and preventing in health, and how are we looking at, now we know that viruses, and we knew before, but the pandemic has demonstrated it very clearly, viruses can cause a very big health burden, not only acutely, but also chronically as a long-term condition. And I think we need to have a paradigm shift of thinking about viruses as risk factors for health. Things such as, things we think about are diet, smoking, physical inactivity, or even air pollution, outdoor air pollution. We deal with these things in public health as risk factors, and we try and adapt our systems so we can navigate them and counteract their bad effects. And I think viruses, in terms of what they cause, in terms of post-viral illness, should be under that category. We need more research and understanding of how to deal with them and how to prevent them, including looking at things like indoor air as well, to try and reduce the risk of transmitting the virus.
Thank you, Nisreen. Same question to Maria Libura. Maria?
So building up on what has already been said, I would add that one of the biggest reversals in approaches to healthcare following the pandemic is that infectious diseases are not a problem of the past for developed societies. So it's not that developed countries left infectious diseases as a medical problem behind, and it is something that we should think of as developing countries' problem, not caring too much about public health, old-fashioned public health measures, focusing on public health 2.0, 3.0, 4.0, and non-communicable diseases only. And in fact, the lesson is that the prevalence of non-communicable diseases in the developed countries can actually make the crisis linked to infectious diseases even worse. And I think this lesson is still to be actually learned. So it seems that we know this is the case, but the developed societies are not actually following this lesson yet. Partly because the idea of lean management in healthcare, the idea that you don't actually have to keep resources that are not of immediate use, that you can easily recreate reserves. This is still lingering on in our approaches to healthcare management, and that requires a major reversal of how we think about the infrastructure that needs to be supported, even if it's not of immediate use to the problems at hand. But this is an old problem of public health, that we wait for crises happen, you have reports on how we need to have this infrastructure on hold, and then once the crisis is over, political decisions tend to undervalue the funding for those institutions that are quietly working in the background to prevent public health crisis.
Thank you.
Another big issue is that actually pandemic made pre-existing health inequalities worse, and the backlogs created during lockdowns are not over, and they are particularly difficult for populations that are vulnerable and likely to suffer from health inequities in the first place. And this is a big issue in all areas of healthcare and across specialities. And while many people actually welcome the acceleration of digital health, and some see it as a kind of answer to the problem of inequity of access, in fact, one of the biggest challenges that we're facing is to make digital care equal and just, because we are now confronting a growing digital divide, where the upper classes are using digital health tools in a way that really promotes health, whereas the lower classes are often left with like second-grade healthcare, which is delivered via technical means, but is not of the same quality for various reasons, including internet access, digital literacy, but also accessibility of wearables, and so on and so forth. So we have not just old problems that are still with us, but we actually have new challenges that need to be addressed, so that the technological revolution in healthcare, which is awaiting us, will not make us end up in an even less just healthcare system.
Mm-hmm. Thank you, Maria. Savante, while state of the pandemic, what are the big issues?
Thank you. I just want to pick up on a few things that Nisreen and Maria have already said. But firstly, I just wanted to get an idea of whether people are aware of what long COVID actually is, and where the knowledge is at in this room. So just quickly to kind of sum up that, long COVID mostly refers to a kind of constellation of symptoms that develops post-COVID infection, and is kind of defined as symptoms lasting around 12 weeks or more post-infection, although there's differences. Some people are defining it as 4 weeks post-infection, some 8. But the general gist of that is that it's ongoing symptoms that don't resolve after the initial infection. And one of the big challenges with long COVID is that it's episodic. It means that symptoms come and go in waves, and so when you are meeting someone or speaking with someone who has long COVID, you're likely to be reaching them on a good day, and they're showing you the best of themselves, when the reality is that most of that time they're not going to be operating at that level. One of our problems is that we don't yet fully understand the underlying mechanisms that cause long COVID. And there's sort of several schools of thought or hypotheses as to why that is, what the main causes are, but it also means that we don't have any corresponding treatments for long COVID yet. And I think talking about long COVID is quite uncomfortable for us, because it reminds us of this messy middle that we missed in a lot of the early phases of the pandemic, when people were really preoccupied with talking about deaths and hospitalisations or COVID being mild, and it misses this whole bit in the middle, that the reality is that COVID can be a very disabling condition. I think the next phase of that is that we treat people with long COVID as this kind of anomalous different group of unique people who for some reason just haven't been able to get over their COVID, and that ignores the fact that, as we heard earlier, in 10, 20, 30 years' time, we're going to be finding out more about the long-term effects of COVID that will potentially affect many of us who have been infected with COVID now. So I think changing our thinking around that is really important. We also need to think about what long COVID means for us economically. Just from a purely utilitarian sense, we have a really large portion of people who aren't contributing to the workforce. And if they are legally described as disabled, then they should have access to state benefits. So we need to be thinking about what labelling long COVID as a disability means for us later and for people dealing with long COVID. And lastly, just before handing over to David, I think we need to be, comfortable with making decisions based on imperfect evidence that we have about long COVID now, but that align with the kinds of values we want to see in our health system and in society as a whole. And it's important that we start making steps towards that now, even in the face of imperfect evidence around causes and imperfect evidence around treatment. So that's all from me for now.
Thank you, Savante. And David Stetson.
Yeah, first, thank you very much for the invitation here. And our Ukrainian guests, I'd also like to thank you. I believe you're not only defending Ukraine, but you're defending Europe. So thank you very much. And I'll actually talk about Ukraine again because Zelensky said at the start of the war, he was asked about the risk of whether they thought the Russians were going to invade or not. And he said no, he didn't think they were going to invade, the full-scale invasion, but he prepared anyway. And that's very much what has not happened with this pandemic, and I very much fear is not going to happen in any future pandemics. And when we have now, medical historians have been looking back to previous pandemics, they've realized we didn't take the lessons then either. And that really that's a real fear I have, that we're already forgetting. So are we post-pandemic now? Who believes the pandemic is over? You know, it's WHO has said it's not over, but everybody's talking about post-pandemic. And there is two pandemics, you know. A pandemic is actually a pandemic of disease, not of a virus. And we have two diseases being caused here. One's the COVID-19, the acute disease that is happening after we get the virus infected. And the second one we're hearing a lot about today is long COVID. Now, I had long COVID. I still have some symptoms. I was so sick for 18 months that I could not do anything except sleep and sit on a sofa. I had to shut down 3 companies. I have a son who, a year, 6 months after I got infected, he got infected, and he is still sick after 3 years, has not been able to attend school. So he's now at a distance education school, but his entire life's plan has been thrown for a loop. He doesn't know what he's going to do with his life now. He had planned to join the military. Now he sleeps 15 hours a day. And this is not a unique story. The data out there is already about 5% of the world has got ongoing symptoms caused by the COVID virus. And we should not be surprised. The 2 viruses closest to SARS-CoV-2, SARS-1 and Middle Eastern Respiratory Syndrome, MERS. Both of them, we have published research over the last few decades showing that it caused very similar effects to what we're seeing with long COVID. Half of all healthcare workers in Hong Kong who got SARS-1 never returned back to work. Now, think about that now when we're having repeat infections from this virus now. In Sweden, I think I'm going to have a question about this shortly, Sweden has been a bit different about this, but Sweden reported a few months ago that on average, people are getting infected by the SARS virus 2 to 3 times a year. This is scary stuff, and we have to look at what's going on in the data. 20% increase in long-term sick over the last 2 to 3 years. The number of people reporting that they're actively available and looking for work is decreasing, and this is happening around the world. But one of the number one symptoms that people report from long COVID is what they call brain fog, just not being able to think straight. Now, if you think about that, if that happens, what do you think might happen with people? Productivity is going to drop? Risk of accidents, car accidents, plane accidents, is that going to increase? And we're seeing that. The United States is having a year-on-year increases of car accidents at about 20%. There's increasing numbers of near misses happening with aircraft. And we're seeing this again and again and again, and it's all quite predictable from the knowledge we have from this virus. We're even seeing now tuberculosis, RSV, these viruses that are increasing again, and the prevalence in society is increasing again and again. Why? People have been trying to say it was because of lockdowns. We didn't have any significant lockdowns in Sweden, but this is happening everywhere. And there's some good scientific reason to think that we should at least be concerned this virus is damaging our immune system such that we're more susceptible to other viruses and other illnesses going forward. Bank of England, even a year and a half ago, or 2 years ago, said long COVID is a major contributor to the inflation and recession we've been having over the last year and a half. That all got a bit lost with the war coming in to add on top of that.
Thank you, David. And just as you said about Sweden, I did want to follow up on the Sweden issue with a question. You have spent pandemic in Sweden, which had a notoriously controversial policy. And what can you tell us as an eyewitness? What really happened there? What do you think the lessons should be?
Yeah, what about Sweden? That's a common thing that's come up in this pandemic all of the time. The bizarre thing was, before the pandemic came, what about Sweden was all being using Sweden as a argument against immigration. And we were very much the very right wing was using Sweden as see what happens if you have too much immigration, the country's a hellhole. And then virtually overnight we became a darling of the right wing as being the bastion of freedom and liberty. The first thing to realise is when you're looking at an infectious disease like COVID, there are things that matter about how likely you're going to get infected or not. I think Maria mentioned the digital divide that's happened. 80-90% of Sweden has high-speed internet. So when the government said work from home if you can, a huge proportion of the workforce started to work from home. And then we got huge differences of impact of the pandemic at the beginning of the pandemic. So there was the bus drivers, the taxi drivers, the healthcare workers, the aged care workers. All these people could not work at home, were getting sick, and now we're seeing them long-term sick, and we're having problems filling the positions. So Sweden had that ability to have lots of people work at home, so the impact of the virus was always going to be less. We have a far healthier population than most of the world, so the impact was always going to be less. We have the largest number of people in the world that live alone. So if you're told if you're sick and stay at home, you go home, you don't infect anybody else. In somewhere like Spain or Italy or multi-generational households, we are living like with 10, 15, even 20 different people, different ages. The virus spreads very, very easily. So you have to be very careful when you're comparing countries in terms of policy response to try to look at all of these confounding factors to make some kind of judgment. And people aren't doing that, and science has been getting used as propaganda. And that's one of probably the thing that's concerned me the most out of this pandemic. I noticed a sign up here in the back, Association of Journalists. I and several other people literally ended up on the front page of Swedish newspapers because we had been challenging the Swedish pandemic response. Representatives of the government called us a threat to democracy because we did not just follow the government line. Now, Sweden has an independent press, supposedly. However, everybody was doing it tough during the pandemic. The media got government grants to support them during the pandemic. The government grants, one of the rules that tied the getting the money was that you had to not be spreading scientific disinformation. This sounds like a good idea, except how was that defined in Sweden? Well, it wasn't defined, but in practice, it came down to what one man, Anders Tegnell, the state epidemiologist, said. So you now had one person deciding what was science and what was not science. And then the media, because they needed the money, basically following that line. And Sweden is also very much a consensus culture. So scientific propaganda is something that I think you need to fear very much, and that propaganda has spread around the world. I was asked, I think in a question you wrote to me, you asked on Sweden. Right, what was the experience in Sweden? Well, you're all experiencing it for the last year and a half. The only difference was Sweden didn't wait until the vaccines came, and so we had a lot more dead in the first year. That's the biggest difference. Otherwise, we're all living it now, getting sick all of the time and suffering all the consequences.
So, Vante, let me turn to you. You are involved in child health research, thinking about how to improve our system for child well-being. What is the picture from current research, and what are possible implications? What policies shall we consider in terms of families?
So the picture of child health research is actually quite bleak. We don't measure long COVID. We don't monitor long COVID anymore. We don't even measure COVID infection in the UK, so it's not a notifiable disease anymore. So that means we don't know how many people have long COVID, although at last, our last numbers were in March this year, and it was over 2 million people, and then a portion of that will be children. But that also means that we don't have a register of people and children with long COVID, so we won't have a known group of people for whom we can offer treatment once they become available. So that's a big problem. I went to do a review of long COVID policies across Europe and had to give up because I could find hardly any information about state or state health services long COVID policies. And actually, no policy is still a policy position, right? So it says something about who we value in society and who we prioritise. And I think throughout this pandemic, children have been deprioritised and not valued in our decision making. And children with long COVID and their families especially have had this kind of double invisibility issue, whereby people with long COVID, first of all, are invisible largely to much of society, but because it doesn't have a lot of social currency in the way that another serious illness does. For example, a concrete example would be a disclosure of cancer usually elicits a certain response from people, whereas a disclosure of long COVID is just met with discomfort, dismissal, uncertainty. Yeah, well, but you look so, you're doing so well. But children have this extra thing where they are not as able to articulate their symptoms, and they also occupy a lower status in the kind of hierarchical, way that we set up society. So they are over anxious, they are making it up for attention, they just want to get off school. If you're a young woman, then you're overdramatic, you're hormonal, and it all comes back to anxiety. So that's a huge problem children and their families are trying to manage care, with parents needing to take time off work to care full-time for their children. So they're facing huge financial barriers and burdens, as well as the additional financial burden of having to seek private treatment either in the UK or travelling into Europe for experimental treatment in Germany and Cyprus. And it's not just the health sector, we need, I think, multi-sectoral acknowledgement of the problem of long COVID, so that we have education aware and knowing what it should be doing, and what, welfare, as we mentioned earlier about disability benefits and so on. All of that needs to be aligned, because it's not just an issue for the health sector.
Right. Thank you. Turning now online to Nisreen, Alwan, I wanted to ask you about the human dimension of dealing with the long COVID. What do we know about the behavior of people who know or suspect they might have long COVID, and what are the reactions of those around them? Cervante a little bit touched on that, but that's also an area of your research, Nisreen. If you could speak a little bit about that.
Sure. Yes, absolutely. Cervante just started talking about this. I think this is a huge part of the problems we face with long COVID. We'd like to talk about stigma, and we know about stigma from other diseases, things like HIV, other chronic conditions which may have less research and recognition underlying them. And also, obviously, we know about the stigma from having mental health problems, a huge stigma. And I think long COVID has kind of exemplified how stigma can play a part in making an illness much worse. We did research around stigma, and we found that really, really high prevalence of stigma. What do I mean by stigma? So really, there are several, or we've classified them into several types. One of them is experiences of discrimination. So people actually going and facing discrimination when they seek healthcare, when they tell their employers, when they tell their family or friends that they have long COVID, and being treated differently. They perceive their treatment to be different to other people. But there's also and around 2/3 of people we surveyed in a big survey of around 1,000 people said that they experienced that. But about 9 in 10 of them said they had what we called anticipated stigma. So that means they are changing their behavior to avoid to avoid experiencing these painful experiences. So to avoid being judged by others as lazy or making things up, or whatever. So they're trying to change their behavior. Some of them they told us that they hide their conditions, or they've really regretted telling people about their condition. And then the other type of stigma is what we call internalized. So that's basically means people, because of what the reaction of society, because of the wide dismissal and the kind of, I would say, the media coverage around long COVID as well, they are feeling some sort of embarrassment or shame because they're experiencing their symptoms. And actually, when we talk with people, again in our research, we found there's a huge amount of self-doubt about and kind of even talking themselves out of, maybe that's not really long COVID, or maybe that's not deserving of me going and seeking health services because it may not be long COVID, or even if it's long COVID, there's no treatment, so they're not going to help me in any way. So that those kind of processes of people trying to talk to minimize their own problems because of all the the surrounding kind of dismissal around long COVID as a serious medical problem is happening all the time. And I think that there's a really huge need for awareness for people delivering healthcare, but also for people in society, for friends, for family, to learn how to support people with long COVID, and for employers, because like Cervante said, it is largely an episodic illness. it really needs adaptation in terms of, if we want to maximize productivity in society, adaptation into the pattern and flexibility of working so that people can actually work and care for other people and kind of participate in life when they can, but also that they don't risk losing their jobs or making drastic changes when their symptoms come back. So those adaptations, you know, are not necessarily present. And if they're present for people who can do it. I also experienced long COVID, and I was able to adapt for it largely because my job flexibility in terms of physically how I do my job and the hours I do it allowed me to adapt to it and continue in it. But many people don't have that flexibility, and that I don't see active discussions around that sort of adaptation in terms of among governments and employers.
Thank you. Maria, let me turn for your take on the interplay between health system and policy and collective action in society, because pandemics saw a heated discussion about the limits of socially accepted government mandates. We see issues of trust between authorities and society. So my question is, why do we have this problem? And what can we do so we can prepare as a society and as authorities, as public health professionals, for new health events of similar scale? And do you think such events are likely?
So I would agree with one of the previous voices that we are unlikely to learn from history, but we may well examine it and see what we will not learn. But during the pandemic, the government really had, faced a very challenging problem. They had to make decisions quickly while having very limited data and also shifting evidence. So if you look at the early public health communication, you see very incoherent messages being sent to the general public. Like at first, when there was shortage of protective measures, people heard that actually wearing masks would not protect them. Once the masks were stockpiled, everyone was demanded to wear them, and so on and so forth. And those conflicting messages were one of the big forces undermining trust to governments. So on the one hand, managing
Okay. We have a little bit of a problem with the connection. So let's hope.
Yeah.
You're back, Maria. So you can continue.
So when crisis management, especially when you are facing an unknown, unprecedented threat, it is something that has the risk of, actually changing guidelines. But then they need to be communicated to the public in a way that will explain why those changes are taking place. And here in Poland, we had this, order that forbid citizens from going on walks in forests, and it became a symbol of anti-pandemic measures that to the public didn't make sense. So such decisions really undermined trust and made people less compliant when it came to sensible behaviors such as wearing masks on public transport and so on and so forth. But also when you look at the values that different societies hold dear, you could see, and there is plenty of evidence published now, that those different reactions that you had in different societies when it came to complying to public health measures were linked to individualistic versus more collective beliefs. So whether people believe that they are responsible for the well-being of those who are weaker, who are in risk of contracting COVID and suffering bigger consequences or not. And that is a big issue for the future. So in those societies where the collective access is somehow suppressed, I think that's a big challenge to actually bring this responsibility back into the agenda. But also developed societies, or some of them, seem to hold contradictory expectations towards the governments. So on the one hand, they assume the government will keep them safe, and in fact, we could see that government intervention gained some momentum during the pandemic. So everyone expected the state to do something to help the businesses, to protect people, and so on and so forth. But on the other, there is this expectation that the government will not interfere with daily life. And again, you need to have a balanced view on where the limits of government interventions are, on the one hand, but also whether people are willing to somehow temporarily restrict their personal freedom so that they can protect other members of the society. And misinformation didn't help. It wasn't just propaganda, it was sometimes clear misinformation spread on social media. And I think this is one of the biggest challenges now. It's an emergent public health threat that needs to be addressed, and nobody clearly knows how to do it because misinformation is quicker, and to debunk misinformation takes more time than actually to make it spread on social media networks. So yes, we are now in a very different world, and it's a digital world that we are in. It's the biological threats are here, but the environment is where information is gathered by the citizens is mostly from the social media, and I can't stress that enough, that future public health will need to address that, and not just by reinstituting an idea of censorship, as some claim, but also by making the public agencies communicate better using those means with the general public.
Thank you, Maria. Mindful of the time, I wanted to ask the panelists for a quick round. If you want to follow up on any of the issues that were said, maybe said by Maria, maybe the larger issue of pandemic prevention and management right now. I also wanted to ask each of you to think, since we are at the policy also conference, if you think there are any low-hanging fruit measures that can be implemented to do some good by the policymakers. So starting first with Svante.
Yeah, two quick things to pick up on in terms of trust and how we build trust. And I will make it quick. Our data suggests a key thing here is really honest communication about the limits of scientific knowledge. So people, what we know from our data is that they don't want a government that claims comprehensive knowledge about science and pandemic science. They want honesty about the limits of that knowledge and then being willing to change so that they can follow the logic and they can understand why policies may change. It makes sense to them. So that is one thing about transparency and communication. The second thing I think is, we're all politically minded people, but your average person doesn't have the same, distinction between different political bodies, and the idea of government to your average layperson is this broad, nebulous idea that includes politicians, state government, local government, political parties, and that means that the reputation and the actions of particular individuals within those, within government can mar the reputation of the wider government as a whole. So I think that's something to consider, that there's not so much distinction in the eyes of the regular public, as it were. And then thirdly, just to touch on the low-hanging fruit, I just want to sort of put a plug for investing back into our healthcare workforce, who we have relied on to help us through the pandemic, but we have really eroded a lot of the goodwill, I think, that they have operated on. A key example was the lack of PPE in preparation for our healthcare professionals, which was sort of a canary in the coal mine of wider health system issues. I think that if we are talking about Europe as a patient, we should be investing in those members of society who are going to be taking care of that patient. So while they may have a duty to treat, we need to also, keep up our side of the bargain by reinvesting in them.
Same quick question to Nisreen.
Thank you. I agree with what Southampton was saying, all of it really. So let me be quick. I think I'm going to reiterate two low-hanging fruits. One is about what policymakers can do to maximize the well-being and productivity of people with long COVID, which actually could extend to other episodic chronic conditions, which is about providing a workforce that's understanding and flexible enough. I think there is a lot of room for flexibility based on people's ability and circumstances. And that's not really, we need to raise awareness about that, and the policymakers need to urge employers, if they're not, if they have no direct control over it, to actually be as flexible as possible. And I do note that maybe private employers may have more flexibility than very large employers, who may be linked to governments around that. So I think that's one low-hanging fruit. I would agree with Southampton about a good healthcare system, a well-informed as well as obviously well-resourced healthcare system about these emerging kind of threats around post-viral illness, and how to deal with it. And I think I have recommendations. I would agree about the recommendation for trust and science communication, open science communication. Absolutely. I agree with Maria that there's loads of misinformation in social media. I think, and I agree with her comment about, well, this is not going to change and we need to do things much better. And I agree with that because it's not going to change. And I think it's really about putting our honest communication out there, and learning how to communicate in better ways, and learning how to build trust, and to show populations, particularly more disadvantaged, marginalized populations, that we are in public organizations trying to be worthy of their trust. I see a lot about building trust with these communities, saying, how can we make them trust us? Well, how can we show them that we're doing things to make us worthy of their trust? And I don't see that very often. I think we need to show that more. And I'd just like to close, and this is more maybe an invite to science in general, but it's a really shift in thinking. Viruses cause chronic illness. That happened before the pandemic. It was not an area that was prominent or well researched or well publicized, but there's so many examples of it. And now we got to get the pandemic. We got the huge number of people having those post-viral effects. How are we going to deal with viruses as a cause for chronic illness? How can we minimize and prevent, as we did? When first we were quantifying the effects of air pollution, it was very hard because people saying, well, how do you know how air pollution impacts on deaths or cancers, etc. But now we have ways to quantify that, and we have ways to research that and inform policy. And I think we need to move into that in terms of the viruses as exposures to chronic illness.
David?
Yeah, I think we're in a John Snow moment. John Snow was a doctor back in the 1850s who noticed that everyone getting cholera seemed to be drinking water from the same well in London. And he didn't understand why, but he understood something was happening there. And that directly led us to completely rebuilding our water supply systems around the world. They literally lifted and moved buildings in the United States to clean the water. And waterborne disease, at least in the West, has dropped hugely ever since then. But it took time before he was believed and accepted and understood. And we're there now with air, and we've had a huge moment in the last 3 years where different scientific disciplines have come together. And there's been things that were said at the beginning of the pandemic, and physicists and aerosol scientists kind of looked dumbfounded and said, what? We've been working on this for decades with air pollution or whatever else, and that's not true at all. And we've now understood quite a lot now about how viruses are transmitted that we didn't understand and accept before. So we have some really, really low-hanging fruit here if we want to deal with it. Those of you that are getting a bit cold here today, apologies, that's my fault, because they asked me, what can we do to decrease the risk of people getting sick here? And there are people coughing here today. So the windows have been getting regularly opened to increase the ventilation here. You'll notice around the room there are air filters, HEPA filters that are cleaning them. These aren't expensive, what, 100, 200 euros each maximum? And I actually looked at existing building codes in Australia, where I'm originally from, the United Kingdom and Sweden, and the building codes already say that there should be good ventilation that minimises the spread of infectious diseases. And it's not being enforced, and it's not being done. Now, you've probably seen I wear a mask when I think the risk is higher here as well. Nobody likes to wear these things. But I've had long COVID. I've got a kid with long COVID. You do not want it. And every time you get infected with COVID, there's a chance you're going to get long COVID. And that just adds up over time. You know, after about 10 or 15 infections, the odds are better than 50%. You're going to be sick for at least 3 months and perhaps for the rest of your life from this virus. So we can use these low-hanging fruits of ventilation, cleaning the air, and make a huge difference not only to COVID, but all respiratory viruses. We accidentally eliminated 2 types of influenza in the last 3 years. They're gone. They disappeared. In fact, the other forms of influenza seem to have dropped dramatically as well. And that's because of the actions we did during the pandemic. So I'm an optimist, but we have to take the moment to actually take action here instead of, this is uncomfortable, we don't like this, we want to pretend it's gone, let's worry about other things. We really should be trying to get this into policy.
Thank you. Maria, any final ideas from you?
Perhaps a single one, that we should probably remodel our primary education so that from very early stages children learn how to be competent in the area of health, because health literacy and low levels of health literacy are the biggest obstacles to health promotion in general, but when it comes to rational responses to public health crisis, we could see that it's a major obstacle that can cost many lives.
Thank you, Maria, and we wish you all. We all wish you a very speedy recovery from COVID, from your illness. If anyone just absolutely wants to ask a question, please raise your hand. Otherwise, you can ask a question to the panelists after the panel is over.
Super short, just one thing, commenting on what David just said. For you who don't know us, we're not only gathering experts, we're doing advocacy on many issues we are raising today including long COVID. So please expect, at least in Poland soon, a campaign calling for investment in public infrastructure, especially schools, to make indoor air quality better, because this will help dramatically, not only with COVID, but also with air pollution, which is a huge problem, and children and other people, elderly people, are paying cost each winter in this country and in other countries. So this is not complicated, this is absolutely low-hanging fruits. We're trying to do our best. We can still improve in such events like this. That's why we don't invite too many people, but public authorities can and should invest to keep ourselves, our children, healthy. So just this, that we will be advocating and fighting for that.
Thank you for those words, Mateusz Piotrowski. This has been a fascinating discussion, though we are already over time. I think the message from this panel to policymakers is to warn them about this huge risk that goes beyond public health itself. It will affect society, politics, the economy even, and it is a current issue that we really need to pay attention to. Please give a round of applause to all our panelists. And please let me say a final few words of this first day of the conference. We started today with moving words from Oksana Matwijczuk, who actually she has been working on civil liberties, on human rights for a dozen years before even the war started. But that shows, you know, that values are not just one issue. It's all of the issues together that we need to take care of. And what brings us together, all the issues we talked about today, is how we need to take this values-based lens, because it gives us insight into the long-term consequences, into the realm of restraining the out-of-control social, political externalities of bad policy choices. And there are two sides of this. You know, it's about policy efficiency. Yes, we are arguing for those changes because it's efficient in terms of policy, but it's also about the core of our culture. We have heard about the need for serious values-based approach to the issue of Ukraine's future. We were warned of the lingering ethical and policy issues regarding the pandemic. In many ways, we will be judged by the future generations by the way in which we go about solving problems. We need to keep our humanity, at the same time be very effective. As of now, we are neither bold nor effective, unfortunately. Tomorrow we will hear some more discussions, including on the international policies, as well as the interfaith dialogue. And thank you all for being here. I hope you enjoyed this day. This concludes our first day of the conference, and I hope to see you all tomorrow.